Good morning, everyone. Good morning, everyone, and thank you for joining us for Grand Rounds. Again, as we transition back at some point from virtual to full audience, today we're trying a new format. We have three of our fellows here in my office, as we have the pleasure and honor to have Albert Sinusas as our speaker. Just to give you an idea of who he is, Albert is a professor of medicine, radiology, biomedical imaging, and biomedical engineering at Yale. And he's a director of the Yale Translational Research Imaging Center and the Advanced Cardiovascular Imaging Program at the Yale New Haven Hospital. He received his MD degree from University of Vermont, went to complete internal medicine at University of Oklahoma, and then under George Beller, I believe, trained in cardiology and nuclear cardiology at University of Virginia, which was at the time one of the top programs in the country. He joined the faculty at Yale University School in 1990, has remained as faculty member there since then, which is extremely rare these days. He is a standing member and chair of the Medical Imaging and the Clinical Translation of Imaging Science Study section of the NIH. He has been a member of the board of directors at most prominent cardiovascular imaging organizations, including the American Society of Nuclear Cardiology. His research is directed at the development, validation, and application of cardiovascular imaging approaches for the assessment of cardiovascular pathophysiology, including target molecular assessment of myocardial ischemic injury, angiogenesis, arteriogenesis, and remodeling. He's a principal investigator of multiple NIH grants that involve multimodality imaging, and is the author of more than 250 peer-reviewed publications. I personally want to add that I have known Dr. Sinusas from the time when I was a fellow. And I have to say, he's one of the most humble and assuming and collegial individuals I have met in my career, and someone for whom I have the utmost respect. Today, he will speak to us about the application of multimodality imaging for the study of cardiac injury and remodeling. Albert.
All right, thank you for the kind introduction and allowing me to speak at your Cardiology Grand Rounds. So this as disclosure, these are my current NIH grants. I need to disclose that I have a small business grant for the development of targeted MMP imaging that we're trying to move to first in man. So I want to start off and talk a little bit about cardiovascular molecular imaging and how it may play a role in the evaluation of cardiac remodeling. So as you know, with atherosclerosis, there may be a plaque rupture that creates myocardial ischemia. And if the ischemia is prolonged, you end up with myocardial infarction. And depending on the extent and degree of infarction, you end up with post-infarct remodeling. And there are a number of pathophysiologic processes that occur in this. There's inflammation, there's thrombosis, there's apoptosis, necrosis, and fibrosis. And traditionally, we evaluate, anatomical changes or look for physiological consequences. But with molecular imaging, we're trying to identify the disease early and identify the fundamental pathophysiology and molecular processes associated with those clinical changes that occur and physiologic changes that occur. My work recently has been focused on targeted imaging of matrix metalloproteinases and also the targeted imaging of angiogenesis. Both are important processes in the remodeling of the heart following myocardial infarction. So with myocardial injury, you have necrosis, you have inflammation, you have fibroblast proliferation and transdifferentiation, and you have restructuring of the extracellular matrix, and that leads to cardiac remodeling. The remodeling process is complicated, and there are a lot of things that get turned on and turned off. And the goal is to use targeted molecular imaging to track those processes and perhaps to guide therapeutic interventions and track therapeutic interventions. So there's an important role of inflammation. There's the release of pro-inflammatory cytokines. There's activation of matrix metalloproteinases, which then are kept in check with tissue inhibitors of matrix metalloproteinases. And then there's the activation of the neurohormonal axis with fibroblast proliferation. So it's a complicated process. And so if you look on the right, in the setting of infarction, there is decreased angiogenesis, there's increased oxidative stress and increased fibrosis. And that behavior in the infarct zone affects the remote areas of the heart. And the goal is to try to stimulate angiogenesis, reduce fibrosis, and reduce the oxidative stress. And so there are a number of therapeutic approaches and those are both cellular and acellular. And therapies can be delivered intravenously, directly down the coronary arteries. They can be delivered directly into the myocardium, either through a catheter or through epicardial, through a surgical intervention. And our work has focused on hyaluronic acid-based hydrogels in the treatment. And our work also involves the use of recombinant TIMP3 as a therapeutic intervention. So I'm going to talk about the role of MMP inhibitors, in particular recombinant TIMP3, and also doxycycline, which is a broad spectrum MMP inhibitor. And I'm going to focus on some work we did on intracoronary delivery of these therapeutics and intramyocardial delivery. But be aware that there are many other therapeutic interventions that others have employed, and those are shown on the far right. And those include the delivery of growth factors, cellular therapies, or even subcellular organelles. So as I said, the remodeling process is complex. It involves the extracellular matrix, which provides a support structure for mechanical function. It's also a depot for a lot of signaling molecules, cytokines, and growth factors. There's the important role of integrins, which modulate the communication between the extracellular matrix and this complicated intracellular cascade that occurs. And there's the important role of matrix metalloproteinases that regulate the matrix turnover. So there's a large array of MMPs that are involved and activated in this process. We've focused primarily on MMP2 and 9, which are gelatinases, but there are also many others involved in this process. So MMPs are released and then they're released as inactive, and they're acted upon by other serum proteases, and then these activated MMPs then degrade the matrix, and they're kept in check by circulating or local tissue inhibitors of MMPs. And so really the remodeling process is really critically dependent on the balance between MMP activation and TIMPs. And so there are 4 major tissue inhibitors of MMPs, 1 through 4. They each have unique effects, and they're involved in sort of remodeling the modulation of inflammatory processes and play a role in myocardial rupture and development of heart failure. So this imbalance of MMP TIMPs leads to an accelerated turnover of the extracellular matrix. You inhibit scar formation that results in structural instability, ventricular thinning, increased wall stress, infarct zone expansion, and then ventricular dilatation, which then leads to clinical heart failure. So it's really important to monitor and modulate that critical MMP-TIMP balance. So there have been a number of studies that go back many years where people measured circulating levels of MMPs. And in this case, this study looked at changes in MMP9 in patients following acute MI. And they found that the change in MMPs in the early post-infarct period predicted the percent change in subsequent left ventricular dilatation. That those that had the greatest change in MMP activation ended up with greater dilatation of the ventricle. What we wanted to do is go beyond just looking at circulating biomarkers and actually try to use imaging to identify where MMP activation is occurring in the heart. And so we evaluated a series of radio-labeled MMP inhibitors. So these are macrocyclic peptidomimetics that have a structure based on clinical or pathophysiologic MMP inhibitors. And we initially evaluated Indian label compounds, both active and control compounds, demonstrating the specificity for these tracers. And then more recently have been using a tech label compound, which is called RP805. And this is a broad spectrum radio-labeled MMP inhibitor that has a nanomolar affinity for a wide range of MMPs, including 2 and 9, which are critical in the post-infarct remodeling process. So one of our early studies was a pig study where we infarcted pigs and then looked at them at 1, 2, or 4 weeks following myocardial infarction, and then we had a good control group. So we performed MR imaging, we performed our RP805 imaging, and then did Spect imaging followed by thallium perfusion imaging. So we found when you do targeted molecular imaging, you need a reference, and that either has to be an anatomic reference like a CT or a physiologic reference like a perfusion agent, in this case thallium. I'm not going to show the MR data just because of the time limitations. So shown here are our initial images, and these are shown here in transaxial, coronal, and sagittal views. We have matched thallium and 805 imaging. And these are images shown at 1, 2, and 4 weeks post-myocardial infarction. And this is a surgical model of infarction. So through a thoracotomy, we tie off branches of the coronaries. And you can see there is activation not only in the infarct area, but also in the chest wall associated with the repair processes from the thoracotomy. So if you look at these images, there is a perfusion defect with thallium, and in that perfusion defect is focal uptake of our MMP targeted tracer. And we see that here at 1 week. And then over time, the perfusion defect doesn't change, but the degree of MMP activation declines over time. And so we euthanized these animals and evaluated them at different time points. And then we found that at 1 week post-MI, there was probably an 8-fold increase in MMP activation in the infarct area, about 2 or 3-fold increase in the border zone, and about a 2-fold increase in the remote areas. So remodeling is a global process, and the MMPs are activated throughout the heart. And then over time, we saw that decline with normalization of MMP activation in the border and the remote normal regions of the heart. And then if you look here, this just looks at the uptake of thallium versus the uptake of our MMP targeted tracer. And you can see that the thallium uptake doesn't really change, but there are time-dependent changes in the MMP activation that occurs in all regions of the heart. And in collaboration with Frank Spinelli and others at the University of South Carolina, we did careful histologic analysis of the tissue in these animals and evaluated the tissue for local MMP9, MMP2, 7, MT1 activity. And we found a very nice relationship between the degree of uptake of our targeted MMP tracer and in particular MMP2, and that the activation of MMP2 was related to subsequent LV dilatation. So there have been clinical trials that have applied MMP inhibition in the treatment of or modulation of post-infarct remodeling. The largest one was the TIP-TOP trial, which was a randomized phase 2 trial in patients following acute PCI. They evaluated 110 patients that had depressed EF, and then they randomized those patients to doxycycline, 100 milligrams BID for 7 days. And so doxycycline is a weak MMP inhibitor. And what they found was those patients that got treated with doxycycline tended to have preservation of their LV function. They tended to have less dilatation. So shown here is the change in left ventricular end diastolic volume index. But importantly, shown here is the relationship between infarct size of these patients and the change in LVEF. And so for every for over the range of infarct sizes, the administration of doxycycline seemed to be associated with a decrease in LV dilatation in relationship to that infarct size. So they went on to do some secondary analyses of the tip-top data set, and they looked at specifically plasma MMP and TIMP levels measured at baseline and then post-infarct on days 1, 7, 30, and 180. They did a follow-up echo, and they also did a follow-up Spect image to look at infarct size and severity. And so you can see here in blue are the time-dependent changes in those patients treated with doxycycline versus the patients that did not. And the only significant difference that they observed was that the patients that got doxycycline tended to have higher TIMP2 levels. So then they looked at whether the patients had a significant rise in TIMP2 or a lesser rise in TIMP2. And they found that that was related to infarct size and the magnitude of the perfusion defects on Spect, as well as dilatation. And so there was this inverse correlation between TIMP2 activity and outcomes. They also found, interestingly, that TIMP3 at day 30 directly correlated with their Spect defect size. So there is another active clinical trial going on at the University of Alberta in a similar kind of phase 2 study, again, randomizing patients post-MI and post-PCI to doxycycline 200 milligrams followed by 100 milligrams BID. And their primary outcome is changes in left ventricular end systolic volume index at 3 months. They've incorporated in this study MR imaging as a more sensitive way to assess infarct size and regional and global left ventricular function. And the goal is to recruit 170 patients, and the enrollment is scheduled to be completed at the end of this year. So there have been a number of animal studies. In this, I'm showing you a sheep infarct study where they randomized the sheep to doxycycline therapy administered chronically via a portacat that was indwelling over a 2-week period. And they showed that those animals that had the doxycycline had a decrease in MMP2 activity. And they also showed that the developed force was greater in the border region in those that got the doxycycline therapy. So dox seemed to decrease MMP abundance particularly in the border zone, and it increased force development in the border zone, which is critical for this remodeling process. They went on in subsequent analyses to evaluate sort of changes in wall thickness, and they showed that the doxycycline treated animals had thicker walls in the border zone. There was a decrease in MMP2 activity. There was a decrease in ROS activity, both superoxide and hydroxyl, and that there was a greater force development in the analysis of excised tissue from these infarcted sheep. So our work has involved administering a recombinant TIMP3. TIMP3, if you have low levels of TIMP3, that results in increased MMP activity and increased apoptosis and LV dilatation. And TIMP3 seems to modulate MMP activation, sort of transforming the pro-inflammatory macrophages to a reparative macrophage milieu. So Frank Spinelli in the University of South Carolina conducted some studies in a pig model of occlusion or reperfusion where they administered recombinant TIM3 down the coronary artery pre-reperfusion, and showed in this model that the animals that got the recombinant TIM3 at the time of infarction and immediately preceding reperfusion, they had less LV dilatation, they had decreases in infarct size as well. They also showed a retention of left ventricular function and an increase in fractional shortening. So we have developed at Yale a percutaneous model of myocardial infarction. So in our animal lab, we have a digital cath lab and a LoRa FD20. And so we do a balloon occlusion of the LAD after the first diagonal and occlude for 90 minutes. We pre-treat the animals with amiodarone and aspirin and continue the aspirin post-reperfusion. And we're able to, and then we apply serial Spect CT imaging, and we can track changes in perfusion and changes in MMP activation with our MMP targeted radio tracer. So we repeated the study that was done down in South Carolina, but employed our advanced imaging technology. So again, we have a balloon occlusion before reperfusion. We administer the recombinant TIM3 down the balloon catheter, and then we do 3 days, when they recover the animal, 3 days later, we inject them with RP805, do SPECT imaging, and then do thallium imaging, and then hybrid SPECT CT imaging. And shown here are some representative images where we see a thallium defect, and in the area of decreased thallium uptake, we see MMP activation, and this is early post-MI. And we plotted, the standard polar plots and demonstrate that those that got TIM3 had slightly smaller perfusion defects and less activation of 805. We also did cine-CT imaging, and we computed regional circumferential radial strain from these cine-CT images. And shown here is the results, radial and circumferential strain in the control animals, those treated with saline and those treated with recombinant TIM3. And you can see that there was an improvement in radial strain and circumferential strain. There was also less of this kind of compensatory hyperkinesis in the remote areas, and that's important in reducing post-infarct remodeling. So the animals are euthanized. We section the heart into short axis slices. Shown here is the anterior septal MI, and we cut the heart into radial sections, and then we do well counting. And so shown here is the circumferential counts. We see a dip in thallium. We see an increase in RP805 in the areas of decreased thallium uptake. And then we looked at the relative increases in RP805 and showed that the animals that received the recombinant TIM3 had a suppression of 805 uptake and therefore a decrease in MMP activation. So we wanted to, but the delivery intracoronary may not be the best way, and that might require repeated administration. So we're pursuing the more sustained delivery of therapeutics using hydrogels, which can be injected down the coronary arteries in some cases or into the myocardium. And these biomaterials, when delivered into the myocardium, modulate angiogenesis. They actually provide temporary mechanical support, and they can alter the repair and changes in the extracellular matrix. So the novel thing about these hydrogels is they can be engineered and can incorporate drugs or therapeutics, and they can be engineered to degrade at different flow rate or different degradation rates and slowly release therapeutics locally into the injured zone. So there have been a number of clinical trials evaluating these types of hydrogels, and shown here is one of the early studies, which is a first in man using IK501, which was injected down the coronary artery, and then complexes. They didn't really demonstrate a therapeutic benefit, although they demonstrated that it was safe without any adverse effects. One of the more recent studies administered these hydrogels via a catheter, so into the myocardium via the endocardial approach, and they delivered these hydrogels in patients in the early phase post-MI and also in a very late phase post-MI. And this study showed that the patients that got these hydrogels did better on a 6-minute walk test. They had a decrease in New York Heart Association class and a better quality of life. So again, Frank Spinelli down in South Carolina tried to locally release this recombinant TIMP3 via hydrogel. So in a pig model, they tied off 2 marginal branches of the circumflex, and then in sort of just an arbitrary 3x3 grid, delivered 100 microliters of hydrogel into the infarct region. And this hydrogel would slowly release recombinant TIMP3 into the infarct zone. And they followed these animals up over a period of time with echo and MRI, and they demonstrated they had control animals, animals that were treated with just an inert hydrogel, and those animals that were treated with a hydrogel that released the recombinant TIMP3. And the ones that had the hydrogel with TIMP3 had the least dilatation of the ventricle, had preservation of their EF, had reduction in wall stress, a decrease in infarct size, increase in wall thickening. So they demonstrated a therapeutic benefit. They also demonstrated that they were able to actually augment TIMP3 activity within the infarct and suppress MMP9 and also a number of other inflammatory markers. So we went on to repeat this study with, again, using our imaging. So we actually, the surgery was performed down in South Carolina. And then 5 to 7 days after infarction, they shipped the pigs up to us. And then we acclimated the pigs. And then 5 to 7 days after they arrived at Yale, then we did imaging. So we're imaging between 10 and 14 days post-MI in pigs that either received hydrogel or hydrogel that was releasing recombinant TIMP3. And we did our sort of multi-modality imaging, doing MMP targeted imaging, thallium imaging, and CT imaging. And I'll show you the results. So we saw here, so we had control animals, animals treated with just saline injections, animals treated with a hydrogel, or animals treated with the TIMP3 releasing hydrogel. And we saw in the saline treated animals post-MI, there was wall thinning, and that was preserved with both the hydrogel and the TIMP releasing hydrogel. There were, this resulted in decreased wall stress in both groups. So, and then shown here is our dual isotope imaging, and we're looking at short axis and horizontal long axis images, superimposed CT and Spect images. In green is shown thallium, in red is show the 805. And so these are in vivo images. We saw no activation of control animals. We saw increased activation of MMPs in the infarct area where there's decreased thallium uptake, and then reduced uptake in the animals treated with the hydrogels. And when we did ex vivo imaging of the hearts, eliminating the attenuation and the background activity and the motion, we could see that thallium was normal in the controls, and there was a comparable perfusion defect in that anterolateral wall in all 3 groups of animals post-MI. But interestingly here, the pattern of MMP activation was very different. So we didn't see any baseline activation of MMPs, but in the infarcted animals, we saw activation in the infarct area. We also saw it in the atria of the heart. So with that increase in pressure and volume, we saw some atrial remodeling and MMP activation. And it seemed to be in the atrial appendages. But with the local delivery of recombinant TIMP3, we totally suppressed MMP activation within the heart, although we still saw the MMP activation in the chest wall. And so shown here are the results with the thallium perfusion, again, in the 4 different groups. And then here is the MMP activation. So in the infarcts without treatment, we saw a marked increase in MMP activation, and that was suppressed both with the delivery of the inert hydrogel and the hydrogel that's releasing recombinant TIMP3. And then we did cine-CT imaging, and we computed regional strains from these CT images. And then shown here is a polar map of peak circumferential strain in the 4 groups. And shown here is we saw decreased circumferential strain in the saline infarct group, but both therapeutic groups showed an improvement in circumferential strain. So shown here is sort of the relationship between peak circumferential strain and MMP activation. You can see that the worst situation here is in the saline treated groups, and that those that got the hydrogel did better. And then shown here is, interestingly, the degree of MMP activation in the atria. So it seemed like we, in addition to reducing MMP activation in the infarct, we actually reduced MMP activation in the atria as well. So now we've gone on to evaluate some more sophisticated hydrogels, and these are bioresponsive hydrogels. So these are gels that break down in the presence of matrix metalloproteinases and then release the MMP inhibitors. So they're smart polymers that deliver the drug as needed based on the local level of MMP activation. And so these things, again, can be engineered to release the drugs over an extended period of time. So now I have several active NIH grants focused on optimizing the delivery of these hydrogels and trying to make them imageable. So we wanted to incorporate iodine into the hydrogel so that we could actually track the delivery and monitor and verify that we delivered the hydrogel where we thought we needed to deliver it. And this just demonstrates sort of the release kinetics and the degradation of these hydrogels under different exposures to collagenase. So with a surgical model, we placed a grid that allowed us to uniformly deliver the hydrogels in this 3x3 grid pattern. And shown here is a in vivo cine-CT imaging showing the iodinated hydrogel distributed in the infarct region. So, and we had to make sure we're delivering this hydrogel through a needle. And we found that the more iodine you put in there, the stiffer the polymer became, and it became very difficult to deliver the hydrogel through a needle if we added too much iodine. So we had to figure out what was the optimal concentration of iodine that wouldn't compromise the mechanical properties of the hydrogel, but would be sufficient to allow in vivo imaging. And as you can imagine, we saw greater visualization with lower energy CT. So that's shown here. So we see greater house field intensity when imaging at 80 kVp versus 140 kVp. And here you can see sort of in cross section these gels. Now this original gel was a shear thinning gel that it gets delivered as sort of a discrete blob within the myocardium. And you can see the distribution of that in the mid-myocardium here. And you can see here when we have a hybrid Spect CT scan that we delivered the hydrogel right in the middle of the thallium perfusion defect. So now we've gone on to evaluate these hydrogels in a number of acute and chronic animal models. And we wanted to explore in the setting of acute MI and the acute delivery of these hydrogels, what were the hemodynamic effects and the biomechanical effects of these hydrogels. So in one of our early studies, we had 8 animals in which we gave hydrogel, and then we had 5 control animals. And again, we did CT, cine-CT imaging to look for strain and look for hyperenhancement. And so we generated these polar maps of the regional strains derived off these cine-CT images. And then we also looked at Hounsfield density to look for the delivery of the hydrogel in different regions. And shown here are sort of the hemodynamic changes in left ventricular end diastolic pressure, the TI index, which is a functional index, and then this hemodynamic supply-demand ratio off the pressure curves, which gives you a sort of indirect index of sort of efficiency or supply-demand. And so here are shown the time-dependent changes at baseline following the surgical intervention post-MI and after the hydrogel delivery. And so we did see improvements in the TI index, and then we also saw a improvement in this SD ratio. So we also looked at left ventricular pressure volume changes at different time points. So plotted here are the end diastolic volume, the EF, the stroke volume, and the pressure volume loop area. And again, we saw some benefit in stroke volume in EF and those that got the hydrogel acutely. And here shows the changes of acute hydrogel administration on myocardial thickness and strain. And again, we saw the only really change we saw, we saw an improvement in radial strain in the infarct area. And then we saw an improvement in circumferential strain, both in the infarct area and the remote areas, and an increase in thickening due to the delivery of this polymer into the injured zone. So, so now we wanted to move to a chronic model. And so we obtained baseline imaging, and then 3 to 5 days later, we performed a rest stress dobutamine echo. So we wanted to try to guide this therapy both by molecular imaging, but also by echo imaging. So can we define the infarct based on echo and guide the delivery based on a functional signature? And can we use rest stress dobutamine to define the peri-infarct zone or the border zone, this dysfunctional border zone? And so we did a baseline rest dobutamine stress. This is low dose dobutamine. So we're only giving sort of 5 mics per kilo, or at most 10 mics per kilo, to try to augment function in that peri-infarct zone. Then we did a balloon occlusion for 90 minutes. We injected tetraphosphamine during the balloon occlusion to define the area at risk. And then we recovered the animals 3 days later. We did a rest low dose stress dobutamine echo, a CTA, and then a stress tetraphosphamine scan. And then, and that was, the idea is that we would, in the early post-infarct era, we decide which patients are going to need therapy and are going to be at risk for developing LV dilatation. And then based on that, refer them for the therapeutic delivery of hydrogels. And so then 4 days later, we again performed multimodality imaging, delivered our hydrogels, and then did repeat imaging. So shown here, but we've found some interesting things, and I don't know, Mario, if you've seen this with some of the CT studies that you've done, but we see in a non-contrast study that there is hyperenhancement in the infarct zone early post-MI. So about 3 days post-MI, we see hyperenhancement of the CT. And then we do a CTA, and then we actually can see hypoperfusion during the contrast administration. I don't know if you can see my arrow or not.
Yes.
But you can see sort of this hypoperfusion. Then we do delayed hyperenhancement, which better defines sort of the infarct area. And then we do a non-contrast study after we deliver the hydrogel. And you can see sort of the hyperenhancement from the infarct, and you can also see the enhancement of our iodinated hydrogel here. So then we have serial SPECT images. And so here are the baseline SPECT images. Here's the one that defines the area at risk when we injected tetraphosphate during the balloon occlusion. And then we have a dobutamine stress tetraphosphate done at 3 days. And then we have a rest tetraphosphate done at 7 days. And so you can see here that in this animal, the area at risk involved 42% of the ventricle. At 3 days, the dobutamine echo or the dobutamine tetro demonstrated an infarct size of 33%, and then 7 days it was similar, 32%. So now we also wanted to understand what were the true mechanical effects of these hydrogels. So we excised the hearts and we cyclically inflated, and then we perfused these hearts with a UW solution, cardioplegic solution, to sort of keep, to preserve the tissue. And then we cyclically inflated the passive heart to understand the material changes in the infarct area. You can see we inject contrast. You can see the cavity. You can see the hypoperfused area in the infarct area in the myocardium. And then we can look at the mechanical properties. So we did 3D echo of these excised hearts, and we did 3D CT of these excised hearts. And we showed an increase in stiffening in the infarct area. So normally that wall would be sort of passively bulging. That makes for an inefficient pump. You deliver the hydrogel, it stiffens up the myocardium and prevents that bulging that occurs and makes more efficient a pump and puts less strain on the remote areas of the heart, reducing global remodeling. So shown here are, we developed an approach to compute regional strains from these 3D cine-CT images. And shown here are the CT images at baseline, at day 3 post-MI, and day 7 post-MI, and then before and after we delivered the hydrogel, and then the ex vivo strain studies. And you can see here in the radial strain and short axis, post-MI, there is decreased function. And we see that at day 7 and an improvement in function in the border zones after gel delivery. And we see that on the sort of radial strain in the short and long axis. Here are the circumferential strains as well. So in order to define the different regions in the heart, the infarct and the border zone, we used our tetraphosphate superimposed images and set thresholds in the tetraphosphate images to define the infarct and the peri-infarct and the normal regions of the heart. And then we used that to segment the heart for our calculation of the regional and global strains. And so then in a small number of studies here are the pre-gel gradients. So we're just looking at radial strain here, circumferential strain, and longitudinal long axis strain, and then maximal principal strain, and then shear strain. And you can see the gradient from the normal zone to the border zone to the infarct zone. And this is a pre-gel delivery. And then here is the effects of the gel delivery. And this is radial strain, circumferential strain, and long axis strain. So we did see some changes in strain in the infarct regions. So this is just looking at the radial strain, circumferential strain, and long axis strain in the normal in the infarct area, and then sort of the ex vivo strains in control situations and post-gel. And so there are important mechanical effects that occur, and there's stiffening in the radial direction that occurs with the delivery of these hydrogels. So now we've gone on, we're also interested in what are the effects of these gels on local inflammation and angiogenesis. And so we conducted another chronic infarct study where we created occlusion and reperfusion. We assessed the risk area with tetraphosphate. 5 days later, post-MI, we did a dual isotope image with thallium to look at perfusion. And then we used this tech-labeled agent mariciclotide, which is a radio-labeled RGD peptide, which binds to the alpha V beta 3 integrin, which is expressed on proliferating endothelial cells. So it's a marker of angiogenesis, but also is expressed on inflammatory cells. So this tracer looks at both inflammation and angiogenesis. And then after we did the imaging, then we delivered our hydrogel through a thoracotomy. And then, so 7 days later, we then did in vivo and ex vivo dual isotope imaging, again with thallium and again with the angiogenesis targeted agent. And then we did tissue counting and histology. And so shown here is the CT images with the hydrogel within the infarct area. We can see sort of the thallium perfusion defect and the hydrogel within that area. Shown here are the images of the thallium perfusion and the angiogenesis image. So you can see that we see angiogenesis going on in the peri-infarct region. And when we separated the tissue based on the thallium counts into the normal zone, the border zone, and the infarct zone, we saw increases both in the infarct region and in the border zone of this tech label compound that marks angiogenesis. And so just shown here, but what we found is that the iodine in the hydrogel leaves pretty quickly. So already by 5 days post-MI, you can't see the iodine in the hydrogel anymore. And so in these studies, we also looked at the mechanical effects, and we had control animals and animals that we gave hydrogel, and the animals that got the hydrogel had less change in volume, had preservation of ejection fraction, and had improvements in remote strain. And then histologically, we could see that there wasn't really a lot of inflammation around these hydrogels. They really create a blob within the infarct and stiffen up the wall, but there really wasn't a really dramatic inflammatory response to these. So we think that perhaps we are stimulating angiogenesis, and the mechanisms are unclear. So we also have done echo imaging, and this is pretty cool. So you're looking here at a baseline echo image, open chest, and then you're looking at one at a post-infarct. You can see an area of infarction here superiorly. And then after hydrogel delivery, you actually can see the hydrogels within the myocardium. And then if you look at short axis, this tells you how important 3D echo is, because you can see these hydrogel blobs moving in and out of the plane of imaging. So if you were doing 2D imaging, you know you're not tracking strain within a given plane. There's all this through plane motion. And we're developing some sophisticated approaches to track 3D strain in the heart. And that involves combining, looking at B-mode images, 3D B-mode images, and also looking at the raw radio frequency signal coming from the scanner. So we have a modified Philips system that allows us to pull off the raw radio frequency signal. And that allows us to do a more reliable cross-correlation and speckle tracking. So we do surface rendering from the B-mode images and track points based on their shape or energy of curvature. And then we track points in the mid-myocardium based on the speckle features. And then we compute radial deformations in a dense field and compute radial and circumferential strains. So one of the current MD PhD students is currently using deep learning and this integrated motion tracking using this attention neural network, where he, I think this will play a movie here, where he can compute the displacement. Shown here are the radial strains and the displacement vectors using this deep learning approach, and we can color code the strains. So we're computing strains off cine-CT, we're computing strains off the 3D echo, and relating those to changes in molecular signals. Now, interesting, this is a paper from 1973 where somebody tech-labeled tetracycline and showed that in a canine model that tetracycline, radio-labeled tetracycline, could identify the infarct zone. And they did imaging at 4 and 24 hours. And they showed here in these planar images, acquired back in the 1970s, that a tech-labeled tetracycline localized within the infarct area. Now, what we want to do is we want to deliver in our hydrogel doxycycline, but we want to radio-label the doxycycline so we can track the dispersion of the drug, and we want to iodine, and we're going to put it in a hydrogel, and we're also going to put iodine in that hydrogel. So now we have a CT imageable hydrogel, and we have a radio-labeled doxycycline that allows us to track the delivery of the hydrogel and the dispersion and the retention of the radio-labeled therapeutic in vivo. So again, this therapeutic hydrogel would provide mechanical support. It would deliver our therapeutic doxycycline, an MMP inhibitor, and it would provide optimal imaging. So we had to develop the chemistry to, in a one-pot reaction, radio-label the doxycycline, and then we verified the purity using TLC and HPLC, and then we documented the dispersion out of the hydrogel in ex vivo studies. And it looks like we can get a fairly high concentration of doxycycline into the hydrogel, that the radio labeling is highly pure, and that there is a significant retention of the radio-labeled dox out to 24 hours. And then we looked at the biodistribution. So we just injected the tex dox in rats in the tail vein, and we saw that it really didn't localize in the heart, and in fact, the blood activity was higher than the heart activity. But when we delivered the dox via a hydrogel, there was a significant increase in the retention of the doxycycline over the blood. And these agents are excreted, doxycycline excreted through the kidneys and the liver, so it would be an optimal, and primarily through the kidneys, so it's would be an optimal cardiac imaging agent. So then we, in very pilot studies, we decided to push this into a pig. And so we, here is an image 30 minutes post-injection and 4 hours post-injection. You can already see that the iodine leaks out pretty quickly. But if you look at the tech-labeled doxycycline, there's quite a bit of activity within the infarct area and where the hydrogel is. And in 4 hours, there's still doxycycline. And then we excised the hearts, cut 50 micron thick sections, did micro-arterial radiography, and demonstrated the retention of the tech-labeled doxycycline in the heart. And so now the last thing I want to talk about is how are you going to deliver these therapeutics? So we're developing an approach for image-guided intervention. So we take a CT angiogram. It can be an LV gram or in this case, a coronary. We do a prospectively acquired image from CT. We define the coronary anatomy. Then we do a cone beam CT, and we superimpose the cone beam CT and the CT. And then we do angiography, and you can see superimposed coronary angiography on the CT anatomy. So we can, and then we can incorporate also our nuclear images. So we see a CT, we see a perfusion defect, we see our MMP activation. So we can do image-guided interventions. And then the last thing I kind of want to talk about is we're developing a catheter similar to the NOGA, which is an electroanatomical mapping catheter, but replace the electrical sensor with a nuclear detector. And so we inject the animal, or in theory, a patient, with a radio tracer that maps out some molecular signal. And then we map out on the surface of the endocardium where that signal is, if we want to identify MMP activation or inflammation. And then we hit a button, a needle comes out, and then we can deliver a therapeutic, our therapeutic hydrogel or some other stem cell therapy. And we're working with a company to develop some prototypes for this device. And we've done some preliminary sort of evaluation of this beta detection catheter using just simple FDG imaging to define sort of the infarct area and the peri-infarct area. And then we've validated the distribution. Shown here is a PET image of a wedge of myocardium that includes normal tissue and infarcted tissue. And then we did gamma well counting to validate that PET image. And then we also placed our probe on the surface of the heart, and we're able to map out the distribution of that FDG signal. And there are rather than using tech label compound, we could use a compound called rhenium 188 or 186, which is a beta emitter and also has an imageable gamma. So we could, in theory, have a 3D image of the distribution of a radio tracer and then have a local detection of that tracer in the heart. And so we're talking about building a Spect scanner for the cath lab that we could incorporate in the interventional suite that would actually allow us to track the catheter in 3D space and superimpose high resolution beta detection with 3D gamma detection for the delivery of these novel theranostic probes. And so to summarize, I think it's important that we integrate targeted molecular imaging with physiologic changes in perfusion and mechanics in our assessment of remodeling. MMP activation plays a critical role in post-MI remodeling and can be detected with a tech label compound, RP805, and that this compound can be used to evaluate novel therapeutic interventions that modulate MMP-TIMP balance, and that we're developing theranostic hydrogels that offer a unique approach to modulate post-MI remodeling, and that this targeted multi-modality imaging allows for risk stratification and the novel evaluation of therapeutics, whether they be MMP inhibitors, polymers, angiogenic therapy, cell therapy, or theranostics, directly, guided to reduce post-infarct remodeling, and that this multi-modality imaging is critical for guiding the delivery of these theranostics. And obviously there's a lot of people involved in these studies. There's the people in my research group. There are collaborators at Yale, at UPenn, at the University of South Carolina in radiology, and in a number of other institutions. And so thank you for your attention, and happy to take any questions.
Okay, thank you, Al. I am pretty sure that my fellows are really impressed with this presentation. I think you have really covered so much in 1 hour that it's very difficult to sorry, I'm not sure what happened there. But anyway, I have a couple of questions to start. The first one is really simple, but I think maybe some of the folks are questioning why you chose thallium as a perfusion isotope as opposed to a technetium compound in most of your experiments.
Yeah, so because our targeted tracer is tech labeled, we needed another isotope to do simultaneous imaging. And actually thallium, I'm bringing back thallium to the clinic because our new cameras, the CCT cameras, are 5 times as sensitive. So we can do dynamic thallium imaging with a Spect camera and do quantitative blood flows with doses of 1.5 millicuries. So we have a radiation exposure that's down, below sort of the 9 millisieverts, closer to 7 millisieverts. And as you know, thallium is a better physiologic tracer than the tech labeled agents, although we stopped using it because of the radiation exposure.
So in other words, it's primarily because of the different energy peaks that allows you to get the 2 sets of information. But I wonder, does it have any advantage due to the redistribution? I wonder if you can actually use it to detect viability rather than perfusion.
Yeah, so that's a good question. So we do both. So we do actually, when we do the thalliums, we do a 30-minute acquisition at the time of injection. So we can compute a K1 and also a K2, which would be an index of viability. And as you know, the standard approach would be to do, an initial injection and then a redistribution image at 3 hours or so. We think that with, dynamic imaging, we can probably get an estimation of flow and viability with a 30-minute acquisition. That may require one other acquisition at a later time point at 2 hours, but we can get quite a bit of information, certainly about flow with a 30-minute acquisition.
I'm curious about one of the drugs that I didn't see listed among the compounds that can be used to modulate MMPs, and it's one that has been recently tried in some clinical trials, which is colchicine. Do you have any opinion about the potential role of colchicine?
That's interesting. We haven't looked at that. But that's interesting. Again, that's a clinically used compound that may have effects. That's why we've kind of targeted the doxycycline, because that's safe. It's already been in man. We already know how to radio label it. So there are advantages to the doxycycline. It may not be the most potent inhibitor, but the idea is that we're delivering it locally, and so that's an important advantage.
Let me ask you a last one before I give a chance to others. I noticed in one of your slides that some of the hemodynamics changed not only on the post-MI data acquisition, but actually on the post-gel. So when you look at the improvement, the difference between the treatment, the control group, and the stroke volume, I saw that it was a further decline in the stroke volume in the control group. Do you think that's a process of remodeling, or is some deleterious effect of the procedure or the intervention?
I mean, we are seeing acute hemodynamic benefits because you stiffen up the infarct area, you make a more efficient pump. They're actually, we actually see improvements in end diastolic pressures, and I don't really understand that. So there's some very interesting hemodynamic changes that we're still trying to kind of sort out. But you may know more about this tie index than me, but there are some interesting sort of indices that people have developed, just standard pressure indices of function and supply demand.
Thanks so much for the talk. I had a question about where you see nuclear imaging or targeted nuclear imaging fitting into sort of individualized choices for like longitudinal decisions in patients. So just to draw an analogy, today for my patients with ischemic cardiomyopathy in clinic, the role is increase the ARNI, increase the metoprolol, increase the aldactone for all. But there must be a more individualized approach, and I'm wondering where you see nuclear imaging.
Yeah, so there are acute changes and there are chronic changes in remodeling, right? And the chronic changes are more RAS mediated, and the acute changes are heavily dependent on MMPs. And it's important to intervene early. But what we're proposing is a pretty invasive kind of therapy, right? We're injecting hydrogels into the heart. So the idea is that in the early post-infarct period, to evaluate a signature, this person has a lot of MMP activation in the infarct and the peri-infarct period and remotely, and this person is the one that's going to benefit. They're going to remodel and they're going to benefit from an acute intervention. Others, we would say, oh, they're fine. And so it really is, using nuclear imaging for personalized medicine, sort of triaging, identifying those patients at highest risk. And that's what we've shown, is that those that have the most MMP activation are the ones that tend to remodel the most.
Yeah, I have a question here. I mean, in like acute MI, we have this door to balloon thing. And some people are now also looking at like door to unloading. Is there like, do we know about how acute should this therapy be administered after an ischemic event?
So I'm not sure I caught the question. You're asking like how quickly do we see yeah, we see MMP activation in the heart within hours of the insult and reflow. So, again, if you have a permanent occlusion and then you open it up, you have reperfusion injury, there's inflammatory cells release MMPs, so there is an acute response that occurs. Now, the interesting thing is, our imaging agent gets a whole array of MMPs, broad spectrum, right? And what we're seeing, there are different MMPs activated at different time points post-MI. And we're just seeing the bulk activation of any sort of MMP, So it's at some point we might have more specific MMP targeted tracers, but, we don't have that availability right now.
Okay, so in all the animals in the post-MI period, did you notice any increased arrhythmia burden? Or if there is any, did you notice any a reduction in the level of arrhythmia after the administration of the therapeutics?
I'm sure I caught the question. Can you?
I'm asking, have you noticed any increased arrhythmia burden in all the animals?
Oh, arrhythmias. So it's pretty, we inject these hydrogels and they don't even have a PVC.
Well, it's interesting. I was actually thinking from the other end whether to actually, you may reduce atrial fibrillation, given what you show on activity in the atria.
So I mean, we're very interested. So we have a patent actually related to MMP activation of the atria and predicting AFib. And the other thing is, the catheter that we're developing, we think we could use it to guide ablation of ganglionic plexi, which is some people are proposing in addition to pulmonary vein isolation to ablate the gangliated plexi as a way to treat AFib. And we would have a way to kind of localize those off of 3D imaging and also with this beta detection probe. But there's a lot of interesting things with regard to arrhythmias. We really haven't kind of explored that. But I can tell you that these animals tolerate it, and the clinical trials that they gave these hydrogels and other extracellular matrices, they didn't see arrhythmias.
One final question coming from Mark Schrabbing, who runs our nuclear program here, and Andreas Cody, one of our research fellows, and try to combine in one. And it's of all of these compounds or radioisotope that you are right now in the process of developing, which one do you think will be the one that will be closer to a human use?
Well, so this RP805, as I said, we've already met with the FDA, and we're developing GMP grade compound to do first-in-man studies. This has cost way more than we anticipated, 3-4 times as much as we anticipated. And so, our clinical trial has been delayed, and we've just spent a lot of effort getting the GMP compound. But we hope to get that into man. There's the other compound, the mericiclitide, has already been in man for a number of indications, and we have GMP compound available through a company in the UK. And so that is one agent that may actually get to man quicker than our MMP targeted compound because it's already been in man and proven to be safe.
Well, I don't want to abuse more of your time, but I have to say, I hope that this was very inspiring to our young fellows here. I have 3 of them in my room. We have a large fellowship. The other ones are the silent majority right now, but I'm sure they're scratching their heads and thinking that there are other subspecialties besides structural intervention and electrophysiology that are very interesting. And
so,
imaging for sure is one of them.
So, we have a T32, and I would love to have, somebody who wants to do interventional or EP kind of spend 2 years with us, kind of learning imaging to kind of bring imaging into those interventional spaces. I think the future of cardiology is image-guided interventions, and we need people that are cross-trained in imaging and those interventional procedures.
We're gonna take you on that offer. Thank you so much, Al.
All right, thanks.
Thank you.
Thank you.